Okay, great. Well, I'd like to first of all welcome everybody here today for our Benchside to Community Seminar Series. My name is Mark Burke. I'm one of the co-directors of the Developmental Core. And today's session is being co-sponsored by the Aging and Comorbidity Scientific Interest Group, led by Marta Catafalmo, Anne Monroe, Wallace Corbett, and Moises Augusto Rosario. And the purpose of this Benchside to Community program is to kind of demystify basic science and really help to encourage discussion and engagement between the community and the scientific academics. So today we have Jiang Zheng. Will be presenting on his imaging studies involved with HIV and aging. He is a assistant professor at Georgetown University and in the Cognitive Neuroimaging Laboratory. We have, as our community representative, Moises Augusto Rosario, who is a longtime treatment advocate and educator for people living with HIV and AIDS. And our moderator for today is Ms. Samia Abdallah. She is a CFAR scholar and a George Washington undergraduate student. So without further ado, I would like to ask Dr. Zheng to be able to start his presentation.
Thank you, Mark. I'm going to share my screen here. Can you guys see the screen here?
Yes, we can.
Okay, let me just go back to the first slide. Sorry about that. I have an Asian computer, so it's sometimes very slow here. So are you guys see the right screen, the screen with the presentation, or the screen?
We can't see anything right now, so it's not being shared.
Oh, stop sharing there.
Yeah.
Sorry.
It's up now. Yes.
It's good.
Yes.
Without notes, without like a full screen. Okay, that's good.
Without
okay.
Notes, everything looks like a regular PowerPoint.
Everything. Okay, because my screen itself flipped by itself, so I'm just keep notes here. Okay, thank you guys, and thanks Mark for the invitation, and it's really exciting and a great honor for me to present here about our research to the community and to some friends and colleagues here as well. And today I'm going to, so we will not be able to go in very deep, and it's more like a broader perspective. So what the question from my expertise or my research focus, what we can do, and what's the future direction, what we have done so far there. And if any of you is interested, next week I will give another talk to the CFAR as well. For that one, I will have about 1 hour, so we can go to much more details there. Just more like an advertisement here. So as everyone here knows, HIV really, thanks to the antiretroviral treatment here, HIV itself has becoming chronic manageable condition. So people with HIV disease can pretty much live a long life. That is based on our communication with the participants come to our study. But at the same time, there's some comorbidities still affect their quality of their lives, including one is HIV brain disease, or commonly we call HIV associated neurocognitive disorders, or HAND. So this is like based on recent studies, really affecting a large population of individuals living with HIV disease, despite briefly the virus suppression is really successful. So how we can help them, and also how we can understand what's the neural mechanism underlying hand. So that's how be our be a focus of my talk, and also be a focus of our research in my lab as well. So this is my lab, Cognitive Neural Imaging Lab. Here is our lab logo. And for any of you guys interested, this is our lab website. So hand, by definition, this is based on the Frascati diagnosis there. So there's different stages for hand. Of course, we have INI, MND, or HAD. HIV associated dementia basically is going from top to down. Is from mild to most severe form of hand. This diagnosis is mainly based on the neurocognitive tests there. When you're looking at the prevalence of hand, post pre and post cut area here, if you're looking at the data here, you will find it while the most severe forms of hand, HIV-associated dementia, from pre-cut to post-cut has significantly reduced. The overall, the prevalence of hand seems to be pretty much unchanged there, with mild forms of hand actually have on rise here. So this is pretty kind of puzzling, and also it's an important question because it does affect many people's life, and also people with hand. Based on new research, people with hand, they're more likely to have other worse outcome, including biological failure and even with increased risk of the mortality there. So how can help them? While the hand diagnosis now is really a standard model, right? Because with a fractal current here, it's proposed in or like formula in 2007. That's for about 15 years ago. Is still the golden standard for us to define hand stage or severity here. So you have different stages here, and the diagnosis is based on the performance of the 6 cognitive domains here, from executive function, language, learning, memory, motor function, and speed information process, and plus activity and events here. This really moves this field really forward by a lot back in like 15 years ago. But at the same time, this model itself has some limitation here, right? Because if we say a person with a hand, if we think about another disease, if we define them by different stages there, then we'll prescribe the treatment according to which stage they are, the different stage of disease. But with the hand, the potential limitation here is a 2-person diagnosed with ANI, they might have very different cause here. One person might be caused by an impairment in the executive function domain. Another person might be caused by both function domain there. So that means they should have received different type of treatment here. In that case, the model itself cannot really guide the treatment here. So one line of research, we have been trying to think how we're going to use brain imaging and also some animal study here to say, can we propose a neurally based model that would be helpful for treatment and for potentially even to guide some diagnosis, and also to evaluate the treatment effects here. So let's be main focus of our research, and also be main focus of my talk today. So most of our research using MRI scanner. I'm not sure how many of you guys be inside the scanner. I mean, myself, I've been scanner many times. Because whenever we develop a new paradigm or new study, I will be inside the scanner and do the task myself to run through, look at data to see how my brain are functioning or reacts there. So basically, you can see if subject will lie down here, this is the head coil. So of course, for us, we are doing like we start brain here. So we'll be lie down in here, and we lie on the bed, and we put the subject in, and then scan brain here. So MR scanner has been nowadays has really been widely used for both clinic practice, also in basic research. They have they share some kind of technique in common, but at the same time they have some different focus here. So today I will not talk about techniques that will be mainly used for clinic practice. I will mainly talk about techniques that's being used in basic research here, especially for in my lab. So first one is structured mind. What it means by structured mind? Basically, there we want to understand what's looking at the structure at a high resolution, looking at what's the change in mostly in atrophy, right? Whether there is a reduced volume, or whether there is a change in shape, or whether there is a cortical thickness change there, or anything else, or they have enlarged ventricle, or enlarged space between gyri. That's all something we're really interested because it can have consequence on brain function here. This is a real MRI scan of the structure of MRI here. You can see from what you can see from here is a sagittal view here. So you have a ventricle here, and you have our corpus callosum here. It's one white matter to connect our left and right brain here together. And you have your occipital region here, and our cerebellum is here for motor function here, and you have spinal cord down here, and your brainstem will be here. And you have frontal region and the periregion here as well. And then you have limbic system, especially this is a cingulate cortex. We're going to come back later on. So we have a study, we'll talk about how we're going to try to use the cingulate as a potential target for treatment here. And another type of scan is diffusion MRI. What diffusion MRI in research, what we care about is how different parts of our brain is talking to each other. Because if you think back many years ago, right? So when we have two computers want to talk to each other, we have to use a big tape, or we have to use a floppy disk to transfer data between two computers. That's back many years ago. But nowadays, you can use both wired and a wireless connection to make a computer talk to each other. That's very important because that makes our productivity much higher. Same for the brain, for how the brain function here as well. If the brain, different parts of the brain region, they can talk to each other very efficiently. If the communication is efficient, there will be our brain function will be much more efficiently, and we'll be able to handle all difficult tasks. If there's communication between different brain regions injured, then might cause some cognitive impairment as well. So that's how diffusion or diffusion tensor imaging is doing for MRI. Here you can look at the different fiber tracks here. Basically, all the fiber tracks connect to different brain region, and it has different color here. Different color means different coding of the fiber direction. If the fiber is going from left to right, like the corpus callosum, that would be red. Then you have a fiber track into anterior to posterior region, and that would be green. And if you have a fiber track goes from inferior to superior, that will be blue. So different color means how the fiber is traveling. And you also have MRS or MRI spectroscopy. So MRI spectroscopy is important because when we do imaging, right, we have, even we say we try to improve the spatial resolution, but for each voxel there itself is have 100,000 neurons there, and we cannot really direct link to basic neuroscience. With MRI spectroscopy, the nice thing is there we want to understand what's the concentration or change of the different levels of the metabolites might have a change on brain function. That will have much more direct connect to neuropathology here. So this will be the real MRI data you will see from basically for MRI scan. You instead of scanning the whole entire brain, you scan your voxel. If your voxel at different location, then you just estimate the concentration of different metabolites at this location. Using spectral techniques for MRS here, based on how much they have their shift in terms of resonance frequency, their impact on the proton based on the location of the different molecules there. And another techniques also we commonly used in our lab, especially it's probably this is most commonly used MR techniques in the research community. It's called functional MRI. What function MRI trying to do is we try to understand what's the function of different brain regions doing, how they contribute to our as a human cognition here, how our brain works here. So we want to understand at each region or each circuitry, what kind of task they're doing, how they respond to different stimuli, how they handle different tasks. Like when I speak, when you guys listen, have an accent, try to minimize my accent, but you will try to hard to understand me despite my accent here as well. But that's how the brain different region works, right? So it's that's how one of the really for our people in the research field is we really try to understand how the brain works. If it's not working, yeah, for brain disease, like for HIV brain disease, so some disease affect the brain function, how they affect the function there. So this will be more like a very typical functional MRI scan. So you can see from here, because for functional MRI scan, we want to use more like high temporal resolution. So our spatial resolution is even limited. So you can see this image is a bit fuzzy, but after average of lots of trials together, then you basically try to understand, okay, which brain region is be involved in which task or response to which stimuli, or is affecting which disease when this task here. So this is a task-based function MRI. Recent years, there also has a strong push for task-free function MRI. Basically, there's no task. So when a person when inside the scanner, then lie down there either with eyes open or with eyes closed, and without any task. Then we'll try to understand how the different part of the brain region talk to each other, how they core activity. So we can ask, then we can populate the brain into different function networks there. So let's say one of the technique that really gain popularity during last 10 or 15 years, because it has certain advantage there, right? There's no task. It's very appealing for when studying people, when studying the children and both development and also in the degeneration. Like for example, people with Alzheimer's disease, they might have dementia. Then they cannot do a task there. But in the United States, they don't have to do a task. They just scan it and assess their networks there. So so far, any question about the different types of MRI techniques? Okay, so that's the techniques commonly used in research and also in our lab as well. And before I went to move to the some of findings and also some of the really interesting questions, I want to just give a really brief background about the structure, because sometimes some of the things might be important for next few slides to say why the research is exciting, why the findings is important here. So brain this is lateral view here. You can see there's frontal region, there's parietal lobe here, and they have temporal lobe and occipital and the cerebellum. So they have of course, each of them have to some degree different function. Occipital region is mainly for vision, important for vision, and the parietal region is really important for spatial and temporal for concept and object recognition, and the frontal for more like executive function, like attention, control, etc. But of course, this brain regions they actually work together to finish all the complicated tasks here. So this kind of distinction is more like for traditional view and also for convenience for me to discuss results in next few slides here. And you can also look at here. So there you have a frontal lobe here, parietal lobe, and occipital here, and the temporal here. And this is a limbic system, including the cingulate cortex, and they have can be a temporal lobe here as well. And this is a subcortical region. So this is more like looking inside the medial view. This is more like an axial view here. It's kind of if you cut the brain like this way, and here you can see subcortical region here. And also this is, again, this is a cingulate cortex here. So this is our frontal here. It's the occipital region here. And this is our subcortical region, including the caudate, pituitary, and globus pallidus. And this is our thalamus here as well. And this is our third ventricle here as well. So a few years ago, about 3 years ago, we published work. 3 or 4 years ago, yeah, 3 years ago, we published a study there. We tried to understand how different parts of the brain region might be affected in HIV, right? If we think about a different lobe or different brain region here, you think how the HIV brain disease, HIV infection or HIV disease might affect different brain region differently. is which, so the question is which region is more likely to affect people with HIV. Then another question is the injury to which region is more likely lead to hand diagnosis there or neurocognitive impairment. So that's a study we did with student Sarah. So we first look at more like a macro level, right? We just look at different lobe here. So we just look at different big lobe here. So which of the few big lobes is more likely affected in HIV disease? And also what we found is interesting is we found is the frontal lobe is more likely to be affected in adults. This is only looking at adults with that, in adults with HIV. But when you look at the people with hand versus people without hand, it's quite interesting. It's showing a different pattern here. The people with a hand, people without hand, the more likely region is more like limbic system, and the subcortical region is more likely being affected compared to if you look at the patients versus controls here. If you're looking in more in like fine detail here, like for example, you like only looking at the subcortical together, you can look at different parts of subcortical region here. Also, you look at different front region here. So which of this fine structure is more likely affected in HIV disease or in hand? What we found is anterior cortex structure is the most commonly affected region when you compare controls people without HIV compared to people with HIV. But when you're looking at the people with hand versus people without hand, so there are the patients only, the people living with HIV disease only, then you find the both consistent affected region seems to be clouded. If you look at more like this, use different population, it's more like a clouded or stratum, it's more like being affected. So this is quite interesting, is because of the before CAR-T is available back in the 1990s. Back then, in general, we think hand is a subcortical disease. So it's like a subcortical, it's more likely to predict whether people have with hand or without a hand. And especially the caudate or stratum in general. The caudate, the volume size of caudate has a pretty good prediction of the brain function back in like 93 or forget the studies, 95 or 93 there. What this suggests is really caudate has played an important role in hand. Now, since the available CAR-T, people start thinking question whether the subcortical region is still the best region to predict hand. Because now, if we're looking at people with HIV with hand in general, they think the both frontal profile and the subcortical profile. So frontal might play also an important role here. What our finding here is suggesting that even the frontal region is seems to be, we compare patients versus people with HIV without HIV. Yes, frontal region is more likely the region being affected. But what's most likely caused hand or neurocognitive impairment in people living with HIV seems to be subcortical region still play a dominant role here, suggesting the HIV disease ongoing HIV replication or because of the inflammation or because of or even probably caused by the medication they're taking, right? We know that some of the antiretroviral medication may also play a determinant role on the brain function, but suggesting subcortical region still probably HIV disease itself is still at the core of the hand, even when the CAR-T is available, people are taking CAR-T with a successful virus suppression here. So based on this finding, we propose the really simple model of a hand. So we want to say, can we use, instead of just doing behavior assessment, can we define which brain region is more likely being affected at which stage, the more advanced stage of hand or more early stage of hand? So this model is based on the data we just proposed. Even in cognitive normal individuals, even with HIV, will be very mild injury in the brain because due to also below there's still some very mild chronic inflammation going on among many other things there. But back in this early stages or in this mild stage, the injury to the prefrontal region is more likely to play a major role. So that's kind of fits with what we know in the CAR area, because now with the antiretroviral treatments there, the most likely affect cognitive domain occurs executive function. That's of course, although frontal region is play a central role there. But what we want to make a prediction is in people with hand, actually to a large degree, they are still driven by the injury to the subcortical region, especially the striatum and caudate here. And frontal region, of course, will persist and it can even get worse. So this also doesn't exclude there may be one individuals who have hand or even dementia is totally caused by injury to the frontal injury. It's still possible. This body just say by large, if you look at the whole population, then hand is more likely still caused by the subcortical injury, especially to the striatum and the caudate here. So based on this model, I mean, we can make a few predictions here. So one prediction is the injury to the frontal region and the anterior cingulate cortex is highly prevalent. The mind, so in that case, the mind circuit can potentially serve as a target for treatment. And also hand status is better predicted by injury to the striatum and caudate here. So if a person with a hand, then maybe the treatment target should be more like focused on the striatum or caudate here. And what can be also, of course, we want to understand what can be factors can contribute to this kind of profile here. Based on our suggestions, they can have different contributing factors, like a medical, clinic, HIV factor here, including CD4 later, as you say, your lost CD4 numbers. That means suggesting whether they have a history of immunosuppression, and how deep you go down there, and how long you have disease, and what kind of medication you're taking extra there. And of course, including your current CD4 and current very low as well. And at the same time, comorbidities might also contribute to hand, because we know some of the comorbidities are much higher in people living with HIV compared to the general public, or compared to HIV unaffected population, including depression. Depression is about 2 or 3 times higher in people with HIV compared to people without HIV, and also substance abuse disorder and hypertension, HCV infection, diabetes, can all play a role here. And another factor is can host genes. Some types of host genes can also play a factor here. That means can the host gene interact with HIV disease to make certain individuals more likely have cognitive impairment? So this question we try to understand, and also briefly touch in a few slides what we have been working in this direction here. So the first study we did is we wanted to understand how the CD4 later can have an impact on brain structure here. So this is our basic understanding is how the history of immunosuppression can link to brain atrophy here. So what we found is the history of immunosuppression made by CD4 later can be linked to widespread cortical atrophy, especially in frontal and temporal region here. This study by grad student and postdoc Shiva and Kayo. We also been studying what can be comorbidities in people with adults with HIV can have an impact on brain structure and function. So this is studied by Margarita, Niels, and Kayo. So here we just basically trying to understand whether depression is associated with any brain structure or brain atrophy. What we found is yes, the current depression symptoms have a strong impact on hippocampus, and also also is clustered in the occipital frontal as well. That's the region we know in general public is affected by depression. But then we can ask another question: is can the depression interact with HIV disease in affecting the brain structure? what we found is HIV and HIV disease mirrored as CD4 later here, and depression seems to be additively affect the brain structure. So they don't interact, they're more like additive, they have additive effect on brain structure here. There's a host gene here. So we did another study, so we understand how host gene APOE4 is the strongest genetic risk for late onset sporadic Alzheimer's disease. So we want to understand how whether APOE4 can also contribute to cognitive impairment in people with HIV here. This is busy figure, but the take-home message here is yes, indeed, for people without APOE4, CD4 later have a doesn't have really have strong impact on the brain, on the memory network. So this is a functional activity of the memory network here. But for people with APOE4 gene, then not only the overall they have lower connectivity, that means their network is communication is less efficient. But if you have APOE4 and have a lower CD4 later, like your CD4 later is less than 200 cells per microliter there, then this impact is even stronger, suggesting if a person with APOE4 and with history of immunosuppression, they might be at a really high risk of future neural cognitive impairment. So the host genes and HIV disease can interact with each other.
There's Young about 5 minutes left, so we can give
Okay,
time.
sure. Okay, sorry. Okay. Yeah, I'm gonna go fast here. So that study, I'm gonna go lot into detail here, but the basic idea here is for if you compare controls, patient versus control or impairment, hand versus low hand, inflammation plays a role. At the same time, neuronal dysfunction also plays a significant role here. So this is our model, and we identify different regions, like this key region, anterior cingulate cortex, and also disease, comorbidities, host gene, and neural dysfunction. They all play a role with the hand. So we, as based on our model, right, anterior cingulate cortex is one of the most commonly affected regions. That means it might potentially be a treatment target here. And also based on here, we identify two contributing factors in inflammation. So we can have probably by changing the medication or enhancing the CART. But what we can do with neural function here? So for us here, we're doing neuromodulation. There are two types of modulation. We cannot get into details here, but we in this study we use transcranial recurrent stimulation. So you see really weak stimulation. It can be well tolerated. This is collaboration with a colleague, Peter Tartau at Georgetown University. And as I said, for instance, we tried with our subject. I would try myself first. So I put on myself and to see how they feel with the stimulation here. And this is a study we did. So basically we have two phases. In phase one, it's double blinded. So patients will be randomized to receive sham or real TDCS for 10 sessions. Then we have both pre-baseline and three follow-up assessment using MRI and behavior testing. And after they finish the first phase, they will be unblinded. The people receive sham during the first phase, then we'll be give them the opportunity to come back to receive real treatment. Then we'll be assessing again. And based on some simulation, because we want to stimulate the anterior cingulate cortex. So this is how we, based on modeling, we choose a different region, different electrodes we want to put on to stimulate brain. And after the 10 days of the treatment, what we found is individuals receive the real treatment. They perform, you have a significant improvement in one of the commonly used tests. It's called Wisconsin color sorting test. That's a very most commonly used neural second test to assess executive function, because we stimulated also ACC, that's one region. This each symbol, each marker represents one subjects. It's pretty striking is we find it for every subject. After they receive real treatment, they have reduced error. We call predictive error. This measurements has been associated with dorsal ACC by many other studies, including the lesion study. So doing lesion mapping, so which region is more likely associated with impairment to this neurocognitive test. That's what the region we are stimulating in this study. We're also doing a function connectivity to see how the treatment is going to affect the brain function. The ACC connect to other parts of the region. What I found is interesting. After treatment, the connectivity between the ACC stimulated region and the dorsal stratum actually is increased, suggesting the communication between them getting improved here. There is some less correlation between improvement in behavior testing and also in the behavior testing and in the structure function connectivity here. That's all. That's all I want to discuss today. And also, first, I want to just thanks for our participants and the district communities. It's really without you guys, I mean, this study is impossible, and we really rely on your volunteer and rely on your help to help us to understand how HIV affects brain disease, how we can help people to improve their function. Hopefully in future we can find an effective treatment for hand, because as of now we don't have really effective treatment for hand yet. Rather than just give them change the medication to help control the inflammation, but as we're showing, right, inflammation is one contributing factor. Neuronal dysfunction is another contributing factor. So how we're going to improve the neuronal function here is a big role here. And also I want to thank of course, I can't do the work. So it's, I thank everyone in my life, especially for HIV, for the community. Many of you, if you did a study with us, many of you might know Margarita, and she has been spent a lot of time to help us to recruit and test subjects. And we also have our two new RA here to help us, and our graduate student, medical student, and undergrad student. They also play a really important role in our research here. And my colleague here, and this CFAR really, I think the first time I did a HIV study is after talking to Alan and Maya about 10 years ago. They really convinced me. It's a really exciting field and to apply my expertise and to understand some of scientific question at the same time to help the community to move this field forward. I also like to thank my funding agency. I'm really glad that Dr. Barvis can join us today. I'm really exciting, and I'm looking forward to help from you about how our research, I mean, what's the impression there. And also thanks the opportunity to talk to you guys, and now open for questions and feedbacks.
I wanted to hear Moises' thoughts and opinions. Have the floor.
Yes, thank you, everyone. I am Moises, and I'm a person living with HIV. I got tested in 1986, tested positive for HIV. So I've been living with HIV for more than 30 years. I really appreciate and want to thank Dr. Sion for the information presented today, and also for making an effort to communicate with us, people living with HIV, about basic research related to hand, right? It is important that we have dialogues between the provider, the researcher, but also the person living with HIV. And for all of us, understanding, seeing that there is no treatment for hand, and that there's some basic research that can lead us to, to a potential treatment, but also to understand how the brain works, to help us identify if there is any functional issues with the brain, any structural issues with the brain, networks communicating properly. All of that knowledge and looking for ways to understand that is critically important for us as we have to face, potential symptoms from neurocognitive impairment, and how that, facing that could affect our quality of life, and also how we deal with other comorbidities as we age. And we being the people over 50, the first cohort people aging with HIV, is very important for us to, connect this knowledge about neurocognitive and how it works and the potential treatment, but also connect it with our continuum of care. Like you mentioned, that in this, when you're talking about the injury, like how they were contributing factors, like the CD4 nadir, like you mentioned antiretrovirals, which I would be very interesting to understand how. Also, you talked about comorbidities that can affect this. I mean, we are in CROI a couple of years ago, there was a section called the Silver Tsunami, right? And they were talking about, there were some projections that people with HIV over 50 or in the 50s, 60s, 70s may be facing multimorbidities, 2, 3 on top of HIV. So the care of people with HIV, it's going to get more complicated as we age. And there are many things that we're going to be juggling around. But the point that when I work with this community, I like to make is that maybe, as we learn more, we can find ways to delay or to prevent. And, as we prevent diabetes, we know that we prevent it, not only because of the effects of diabetes in our body, but also because all this could be a cofactor, right, for also your cognitive impairment. The same with people that have history in substance abuse, people with hypertension. So, we don't treat these things isolated. The thing about, our brains is, and as a person living with HIV, I get nervous or I get anxiety about thinking, that I may be prone to develop some sort of impairment that would not allow me to live the life I want to live as I move forward. And also, the question that I have is, how can we learn to self-monitor? What are the tools that we can have to start looking at, if we're losing memory? Is that HIV? Is that, the medications? Is that age? Most probably, but that we can own and be empowered to also participate in some sort of monitoring and understanding of that, potential threat of having hand, even if it's, when you mention asymptomatic neurocognitive, what are the kind of assessments that we need to have? So I'm very happy, and I learned, a lot with your presentation. I will encourage other people with HIV participating in this webinar to don't get intimidated by the science. You don't need to understand the details about, what has been said, but at least, have the broad concept, that there is research that is helping us to understand the brain, that they understand if there are patterns that can be related to any cognitive impairment, and also that there are, this research is looking for ways to, help us either prevent or treat, potential conditions of cognitive impairment. So I think that's all I had. And thank you again for also having me here. And I'll pass it to Samia.
Thank you so much, Moises. I really appreciate it. And a lot of the questions that you asked were also things that popped up to me as well, especially when talking about comorbidities and seeing how they're associated with different accessory proteins in HIV. Previous work that I did with Dr. Michael Bukrinsky, who's also here at GW, has seen that the HIV accessory protein NAF is actually associated with the comorbidities of cardiovascular disease, specifically narrowing of the arteries due to cholesterol and plaque buildup, which is called atherosclerosis. So it's just interesting to see how these different proteins can contribute to a lot of the factors that people are seeing. And you're focused on cofactors and comorbidities is actually really, it's a very interesting approach, because that's something that I feel like not only is applicable to people living with HIV, but this is something that's really common among people living with several diseases or conditions. And I think one of the biggest things that I've taken away from both research and my experience in clinical work is whenever you're questioning where a symptom is coming from, the best thing to do is really get a broad sense for, okay, what can I actually measure, or what can I actually look at? So I used to work at a neurology clinic, and there were people that came in with multiple comorbidities, hypertension, diabetes type 2, hypothyroidism, you name it. But what our approach has been at the office is giving a standard panel and having that panel be consistent. If somebody were to come in with memory loss, it's not very fair to always assume dementia, even if they might be of age, because some people might have a vitamin B12 deficiency, and that can really, really impair memory, cognition, attention, and concentration. So I think that constant monitoring is actually something very important. And I'm sure that people living with HIV aren't new to the idea of doing consistent testing, but I think that it might be a good idea for clinical practitioners and researchers to consider non-HIV related factors like vitamins and different reactive proteins that might not necessarily be HIV related directly, but have broader implications in that sense. So yeah, that was something that I was thinking about. And with regards to the anterior cingulate cortex, he had talked about direct stimulation during his presentation, Dr. Zhang. But I was interested in hearing about transcranial magnetic stimulation, something that can be done over time and possibly used as an entry point to helping alleviate some of the cognitive aspects of the disease. Yeah.
Okay, thank you. Excellent question here. Should I respond now, or should I wait for more questions?
You can respond now to especially the transcranial magnetic stimulation one. That's
okay.
Yeah.
Yeah, thanks to Samia and Moses there. A really excellent question here. So I guess I can go backward to respond here. Yeah, first, Samia, yeah, you're right. So there be as we discussed, right? In most companies use the non-invasive brain stimulation. Is one is TDCS, what we did. Another one is transcranial magnetic resonance stimulation, or TMS there. So there are some difference between these two. So TDCS in general, they do not excite neurons really. So their stimulation is really weak, is relatively weak. So it basically changes the membrane potential to make the neurons there more likely to fire. Compared to TMS, they actually directly excite or inhibit the neurons. So they have a stronger impact there. And the advantage of the TMS over the TDCS is more focal. So you can really define, you can much better define which region you're going to stimulate there. And also in general, we think this effects will be stronger and probably last longer as well. The advantage of the TDCS is more or less actually diffuse. It can also make sense there as well. We want to have diffuse influence there, but more like, from my perspective, its key advantage is how to say, it's much more cost efficient. So it's because you just basically, if you think of the basic device, you just need a battery, then electrodes. You can so that would be, especially if you think about it, people in Africa, right, or people in like in Thailand, or people in other countries with more like less resource there. Using TDCS might be more, how to say, more applicable, more feasible there if we find that there is treatment there. And also the TDCS in general there is more tolerable. So its side effects associated with TDCS is really mild. We don't have any, people have used TDCS for many years now. There's no single incident of the severe adverse event. And also with TMS now we learn how to limit the amplitude, also allow risk years, the adverse events also much less likely to happen, because one of the side effects associated with TMS is seizures. But now we know the amplitude, how to control them, is more likely side effect. But at the same time, TMS sometimes can still cause some other like side effects like headache, nausea. Compared to TDCS, is more like much more tolerable. So that's why we choose TDCS. But of course, your question is really important, because if we find this region is really important, and then we find this effective, then if we can, since we know how to limit the TMS amplitude, the strength of the TMS stimulation, then we can apply TMS to treat people who really need help to improve the function. And we think this region is really going to help them. That will be something probably we're going to do in next few years. So because now we want to first confirm the region we select to stimulate is really helpful, because as we said, right, it's a pilot study. We have really, the budget is really limited, and also due to the pandemic. Before the pandemic, we have a few subjects we need to finish, then we'll never be able to finish them. So the total number of subjects in this study is only 11. So it's really, really a small pilot study there. So we want to be able to first confirm our findings with a relatively larger sample size, maybe like 30 or something like that. Then we can confirm, then we can apply, say, okay, this region is really helpful. Then we can move forward with TMS, say, we're going to use TMS to compare TMS and TDCS at the same time there. Yeah, so that's with stimulation. Another question is with comorbidities here. Yeah, comorbidities is really, I think it's there's a debating in this neuro HIV field. So for some research, they think the hand is mainly now is not joined by HIV disease, and it's more likely joined by comorbidities. Like something like you talked about it, and Mercy, like you was talking about it, the hypertension, vascular disease, and other factors there, like HCV or diabetes, they all might play a role here, and also include depression. And to some degree, it's true. What when we look at individuals who diagnosed with hand, many of them might indeed be joined by, instead by HIV disease per se, might be joined by comorbidities. But at the same time, the comorbidities, some of the comorbidities actually they have high synergy with HIV disease per se, right? Because we know HIV disease and also the medication taken is going to have some impact on the vascular function there in the brain here. So they might also have the consequence there as well. And also based on our studies so far there, we think HIV disease is still one of the main contributing factor for hand. At least based on our model, and also that's what we think is probably still likely the case. But at the same time, you have other factors, affect cortical region or cerebellum and other or white matter. They might also play a role here. And also, I want to point out is our model is really simplified, so it's really just as a first step. I think there is improvement, and they might have some incorrect assumption here. For example, our model we don't talk about white matter, because we know actually white matter is important, right? Because it can connect different parts of the brain region to help them communicate. That's important for our brain to function as normal. And also we know by post-mortem study, the virus concentration actually is higher in white matter than green matter in the brain here. But we are working in this direction right now, but we have finished our study there. So once we finish study, we revise our model to combine not only green matter injury, but also white matter injury, also with metabolites and some other circuitry there together with more comprehensive model here. And I guess another question is, good.
Oh, I was gonna say, I like the idea that TDS is more tolerable. And I was gonna say also that even though I'm sure you'll be able to get to a point where you are going into trials with TMS, I like the fact that better tolerance is equated to better quality of life. And honestly, I think that's the most important thing. I'm sure Moises would agree with me that, I mean, treatment of hand at what cost? So speaking of aging in general, what are more topics that you want to hear about, Moises, or anybody else in the community that's willing to go off of mute and talk a bit more about comorbidities and aging? That was something that I've been really interested in learning more about, but obviously we're here for more perspective.
Yeah, I think that it would be, this is a great start to, start some series of sessions to talk about comorbidities. And I think that, when we talk about the intersections, I think that would be the word among comorbidities, you have to keep your blood pressure down because that may affect your cognitive impairment, or you know what I mean, if you don't exercise or you're obese, that's going to affect your hypertension. So it would be great to understand each one of the comorbidities that we know are more common. Let's say diabetes is important, hypertension is important, mental health is important. Also, let's say some people present frailty, but what I would recommend is that is done in a way in which these comorbidities are intersected, that are part of a way to monitor. Like you said, at what cost we're going to monitor one comorbidity over the other. And, and keep in mind that it's a full-time job to live with HIV. And that we're going to have more ways to prevent some things, but at the same time we need to be conscious about how we give the skills to the patients so this doesn't become a burden, and that we can learn about how they intersect and how we can live a better life even when we have to monitor and work with our doctors on this.
Yeah, certainly, yeah.
Well, I think,
Yeah.
can I jump in? I want to say a couple things. I think this is really interesting. And one of the things when you talk about monitoring brain function over time, there are devices out there. You have CanTab, for example, that has about a dozen or so different measurements of processing time and things like that. And and some of these things are in general for people who are aging. I'm getting close to 50 now, and I'm thinking I'm not remembering things as quickly as I used to. We all remember our grandmother who would call us all of our brothers and sisters' names before they actually got to our name, right? But then you add in on top of that the HIV diagnosis and the antiretroviral therapy you take over time. That adds a whole new perspective to it as well. So you can have these kind of easy tests to do, like CanTab, processing time, executive functioning things. And you can do that on a yearly basis to say, okay, am I losing my mind or am I not losing my mind? And then compare that to people around you, right? So there are ways of measuring that. And one thing I will say about the imaging studies, that these are amazing imaging studies, Young, and I'm really happy that you shared that with us today. But I think one of the other things, and I'm sure you get this quite a bit, Young, is that when somebody comes in for an MRI, why can't they get that pretty picture of their colored brain when they leave? Because there's a lot of computational processing that has to go on with any MRI or any sort of imaging task, right? So those are things that as subjects we have to keep in mind as we go in for these different things. Well, we can get a black and white picture, but doesn't tell us anything about thickness of different regions or anything diagnostic like that. But when you add it in with 50 other people, then you can start to say, okay, well, there are some differences here. And that takes a lot of computational power to do. So we are running out of time, but I do want to say thank you to Jiang, Moises, Samia, and especially our community for being here today. I've been taking notes, and it sounds like we do want to continue this Benchside to community and talk more about comorbidities, intersections, cardiovascular health. So I'm glad Anne and Marta are here, so we can start thinking about who to invite next for these different comorbidities to talk about HIV and aging.
Yeah, thank you, Mark, and Samia. Yeah, it's good discussion. Although I think I'm really missed the opportunity to see you guys in person before the pandemic. So hopefully in future we can have the more like hybrid, so we can then, because it's have been fun. I mean, during the previous event hosted by CFAR, I get to talk to the community members, and some of them come to do our study, and they really like our study, and they have been spread out information and help us to really with the recruitment. So let's say, sometimes it's you want to have a study, but it really depends on people who come here to volunteer. So
And for our community members, if you do have a specific topic that you would like to have us cover for our Benchside community, please feel free to reach out to me. My name is Mark Burke, mark.burke@howard.edu. My contact information can be found on our DC CFAR webpage as well. So please feel free to reach out to me.
I just wanted to second Dr. Zhang and say that the idea of research as a feedback loop is really something that I'm looking forward to exploring more. Moises, your input was really something that got me thinking beyond just the academic perspective, but centraling back to the idea that this is an everyday thing and it should be treated as such. Thank you.
Thank you, everybody, and have a great rest of the week.
Thank you.
Mark.
Have a
Thank
good
everyone.
time.
Bye, everybody.
Bye.
Bye.